I think we had enough fun talking about gastric disorders, and we're going to go on to liver and pancreas disorders. So, of course, the outrider on the liver is the gallbladder, so we'll talk about the gallbladder as well when we're talking about the liver. So, gallbladder disorders, I love the names of the gallbladder disorders. I don't know why, I just like weird words, but cholelithiasis is gallstones. There's solid material that forms in the bile. They call the stones calculi. A lot of times the calculi are formed from cholesterol. There's a really good picture in the book with some mixed gallstones, and you can see how it's just packed with them. The gallbladder is just packed with gallstones. Cholecystitis is inflammation of the gallbladder and the cystic duct. So itis, it's inflammation. Cholelangitis is usually related to infection of the bile ducts. And then choledocholithiasis, isn't that a great name? It's obstruction of the biliary tract by gallstones. So the gallstones are the primary problem, and then the tract gets obstructed because of those gallstones. So here's a nice little picture of the biliary duct and the pancreas with possible locations of gallstones. So they can be in the gallbladder, they can be in the duct, they can be in the common bile duct, or even far down where the pancreatic duct starts to join with the common bile duct and go into the duodenum. So they can cause a lot of problems. They can cause problems in the liver, they can cause problems in the gallbladder, they can cause problems in the pancreas if they're obstructing. So a lot of times people will have, if they have gallstones, as the gallbladder fills up with bile that's created by the liver, it takes a hormonal signal to cause it to contract and shoot that bile into the duodenum to help digest that fat. Well, if there are gallstones in that too, if they're really big like the picture in the book, they're not going anywhere. They're just going to obstruct. But if they're smaller ones, they go out through the bile duct, and a lot of times they can cause pain. So that's a lot of times the first symptoms that people get with gallstones is they get that pain. So gallstones can vary in size and shape. They can form in the bile ducts, the gallbladder, or the cystic ducts. They can be cholesterol or bile pigment, and the picture in the book, those are mixed ones, and so those big fat ones are cholesterol ones. Sometimes they can be mixed with calcium salts, and small stones, they say, may be silent and excreted in the bile. The small calcium ones are super pointy and super painful. So the bigger the stones, the less likely they are to be excreted and build up in the gallbladder, and so then they don't cause problems until they're in an obstruction later on. So the smaller stones, a lot of times they're just excreted little by little. Larger stones can overflow either into the cystic or common bile duct. They can cause severe pain, and the referred pain pattern is the mid-back or the subscapular area. So it can fool you as to where the problem is coming from. Risk factors for gallstones: women are twice as likely to develop stones as men, even though men do develop them. High cholesterol in the bile, high cholesterol intake, obesity, multiparity, which means you've had more than one child, use of oral contraceptives or estrogen supplements, hemolytic anemia, alcoholic cirrhosis, or biliary tract infection. The lucky people who form calcium stones rather than cholesterol stones also can form calcium stones in the urinary system, and we'll talk about that when we talk about the urinary system. And those ones, calcium stones are pointier than cholesterol stones, and they're supposedly more painful. So if there's an obstruction of a duct by a large stone, a large calculus, it can cause sudden severe waves of radiating pain, and the pain rate can radiate to the subscapular area. It can cause nausea and vomiting. The pain can, as the bile backs up, you can develop jaundice because it backs up into the liver and blood. And so jaundice is that yellow coloring because the bile is that yellow color. And you're risking a ruptured gallbladder if the obstruction persists, and it can end up causing liver problems as well. Pain decreases if the stone moves into the duodenum because it's a bigger duct and it can be moved out then. A lot of times surgical intervention is the treatment for gallbladder disorders. Nowadays they can be removed using laparoscopic surgery. 20-25 years ago it was a more involved surgery, and for some types of gallstones, a low-fat diet is necessary following surgery. It depends on the cause, and the physician will decide what happens. So when they remove the gallbladder, when they go in for the gallstones, sometimes they just remove the stones. Sometimes they remove the whole gallbladder because it's going to keep forming stones. So you can live perfectly okay without a gallbladder. Jaundice can be caused by a lot of different things. So there's some different classifications, and it has to do with where it originates. So prehepatic jaundice is a result of excessive destruction of red blood cells, like in hemolytic anemias or transfusion reactions. So that happens before it gets to the liver. Intrahepatic jaundice occurs with disease or damage to hepatocytes, which are those liver cells like hepatitis or cirrhosis. Posthepatic jaundice is caused by obstruction of the bile flow into the gallbladder or duodenum, either caused by tumor or cholelithiasis, the gallstones. So if you had gallstones and you ended up jaundice, it's posthepatic jaundice. If you have hepatitis or cirrhosis and you ended up with jaundice, it's intrahepatic jaundice. If you have jaundice because of hemolytic anemias, it's prehepatic jaundice. Makes sense? So this is the chart from the book that has the different types of jaundice and how it is formed. A lot of times, I think there's a picture in the book too of what someone's eyes look like with jaundice, so maybe not. Anyway, they look yellow. Like the whites of your eyes look yellow, your skin looks yellow. It's definitely a very noticeable sign. The type of jaundice indicated by an increase in serum is indicated by an increase in serum bilirubin level and changes in stools, because the jaundice is caused by a backup of bile. Bile is part of fat digestion, and so if you're not properly digesting fats, it's going to cause changes in the stool. Prehepatic jaundice is going to show up as an elevated, unconjugated bilirubin level. That's something they can blood test for. Intrahepatic jaundice is going to show up as both conjugated and unconjugated, and post-hepatic jaundice is an increase in conjugated bilirubin level. And sometimes it results in a light-colored stool, which is caused by the absence of bile, because you're not breaking down the foods as well, and so it's going to be changes in your stool as a result of that. So here's the liver lobule. Isn't it neat looking? Just like the kidney, where it has tons of repeating units, the liver also has tons of repeating units. So that's one of the reasons why liver can recover from damage better than some of our other organs, because it has all those repeating units and a really great blood supply and a really great lymph supply. So a lot of different liver damage can be repaired by the liver itself, which is pretty awesome because we can't live without the liver. The kidneys, and we'll talk about that in the next chapter, they have all those repeating systems, and so you can actually function with your kidneys being at a much lower level. You can even function with one kidney, which allows for kidney donation in cases of renal failure. So because we have so many repeating units in there, fewer of them can do the job, which is really nice. So hepatitis is inflammation of the liver. It's itis, inflammation, and it can be caused by lots of different things. So you can have alcoholic hepatitis or fatty liver disease. Idiopathic fatty liver disease can cause inflammation. Viral hepatitis, which is a local infection. An infection somewhere else in the body, like mononucleosis or amoebiasis, can cause hepatitis, or chemical or drug toxicity, because remember, the liver is our chemical factory in the body. It's processing and excreting chemicals, and so if you have high toxic levels of chemicals or drugs in your body, the liver has to take the brunt of it. Viral hepatitis, lots of different types of it. The cell injury results from inflammation and necrosis in the liver, and the degrees of inflammation and damage may vary. The liver is swollen, edematous, and tender. All these different viruses can cause it. There are vaccines for some of them and not for others. They are blood-borne illnesses, so we want to use standard precautions and avoid blood-borne pathogens to avoid these hepatitis viruses. Hepatitis A is a small RNA virus. It's infectious hepatitis. It's transmitted by fecal-oral route in areas of inadequate sanitation or hygiene, often from contaminated water or shellfish. It can be transmitted sexually once somebody has it during anal intercourse, so that's good to know to avoid that. It's acute, but it's self-limiting, and it doesn't go into a chronic state, and you don't become a carrier. A lot of times you can shed the virus before you have onset of signs, and there's a vaccine available for healthcare, food care, and travel workers. So hepatitis vaccine, good thing to have. Hepatitis B, there's also a vaccine. It's routinely given to children. It's also routinely given to healthcare workers. It's a partially double-stranded DNA virus. So over 50% of HIV positive patients are positive for hepatitis B, which I think is really interesting. 50% of patients are asymptomatic but contagious because they're in a carrier state. And you can get chronic liver inflammation. Transmission is primarily by infected blood. It can be transmitted sexually because when you swap body fluids with people, you can get blood in along with that. Tattooing and body piercing may transmit the virus. You know, when you take this class, you start to rethink a lot of things like, wow, I'm never going to get a tattoo. Not just because of this slide, but also, you know, it starts to make you question a lot of things, for sure. Get the vaccine. It doesn't make you question getting vaccines. You should get them. It's routinely given to children and healthcare workers, so if you haven't had it, now's the time. Hepatitis C is a single-stranded RNA virus. It's the most common type transmitted by blood transfusion. It may exist in a carrier state, and about 50% of patients enter a chronic state. And it increases your risk of carcinoma. It's treated with interferon injections. So it's interesting that a lot of times now when people have a planned surgery and they know they might need a blood transfusion, they will donate their own blood ahead of time so they get their own blood. Transfused blood is now tested for hepatitis C and several other things. So there's less of a risk with transfusion, but you never know. Hepatitis D is also called Delta virus. It's an incomplete RNA virus, so it needs to live with hepatitis B to replicate and produce an active infection. Hepatitis D infection increases the severity of hepatitis B infection, and it's a blood-transmitted virus again. Hepatitis E is another single-stranded RNA, and it's transmitted by the oral fecal route, and there's no chronic or carrier state. So a lot like hepatitis A, except there's no vaccine for it. So the signs and symptoms of viral hepatitis, no matter what type it is, can be fatigue and malaise, anorexia and nausea, and general muscle aches. Doesn't that sound like a lot of other things? Maybe it's the flu, maybe it's viral hepatitis, maybe it's something else. So pretty vague symptoms to begin with. Then you get the onset of jaundice, the light-colored stools, and urine becoming darker because of the intrahepatic jaundice. The liver is tender and enlarged, and you get a mild aching pain. In the recovery stage, you get reduction in signs, and weakness can persist for weeks with viral hepatitis. Of course, if we have somebody in any setting that we're working in PT that has viral hepatitis, we need to use isolation precautions with these people. We need to use standard precautions, and we need to make sure we use blood-borne pathogen precautions as well. So in the book they have the little stages of hepatitis B infection, where it can get, the fulminant infection is where it gets really bad, or you should get severe necrosis and liver failure, possibly resulting in death. And then the recovery stages, you can recover completely, or you can develop a chronic infection. The only body defense for viral hepatitis is formation of antibodies via a vaccination. So you're not going to catch viral hepatitis and get a decreased form of it and then develop immunity. Vaccination is the only way to do it, to develop immunity. So get vaccinated if you haven't already done it. Supportive measures for treating viral hepatitis: rest, diet high in protein because the liver is trying to regenerate, carbohydrates and vitamins. Chronic hepatitis can be treated with interferon to reduce viral replication, but it's only effective in a lesser percentage of individuals. Sometimes a drug combination of slow-acting interferon to reduce viral replication and an antiviral drug is more effective. So because we have a lot of really nasty viruses out there, there's research going into what combinations are going to be more effective against these horrible things. So there's also toxic or non-viral hepatitis. So there are a variety of hepatotoxins that can cause inflammation and necrosis of the liver, including Tylenol, acetaminophen, and several other drugs that are pretty common. Tetracycline, they use that antibiotic to treat a lot of things. And so these sort of relatively common drugs can cause toxic hepatitis. Chemicals including carbon tetrachloride, which is not currently in use, toluene, which is an industrial solvent, and ethanol, which is also used as an industrial solvent. The hepatitis is caused by the direct effect of the toxins. It can result from sudden exposure to large amounts or from lower dose and long-term exposure. So if you work in a setting where you're exposed to industrial solvents, you can end up over the long term getting long-term exposure that results in toxic hepatitis. Cirrhosis is progressive destruction of the liver. There are different causes of it. Alcoholic liver disease is one cause of it. Biliary cirrhosis is associated with immune disorder, so it's an immune problem where the liver is getting progressively destroyed. Post-necrotic cirrhosis, it's linked with chronic hepatitis or long-term exposure to toxins. So like we were talking about, you work in a setting where you're exposed to industrial solvents. Metabolic cirrhosis is usually caused by genetic metabolic storage disorders. So the liver stores a lot of stuff. It stores glycogen, which is our storage form of glucose, and it stores a lot of our other chemicals. And so you have this genetic metabolic issue that eventually causes destruction of your liver cells. Usually there's extensive diffuse fibrosis that interferes with the blood supply, and it may cause the bile to back up. So the lobes of the liver are very neatly organized, but with cirrhosis, you get that fibrosis that causes you to lose that lobular organization. And the degenerative changes can be asymptomatic until the disease is well advanced. So this is another one of those things that by the time they diagnose it, you're already way past where they can do anything. They do a liver biopsy, and they do serologic testing to determine the cause and the extent of the damage. So a lot of times when you're seeing people a lot of times it's an acute care setting or occasionally in an outpatient setting, people with cirrhosis, it's as a result of long-term other problems. So they've got a lot going on. Alcoholic liver disease, in the initial stage, it's called fatty liver, which is an enlargement of the liver. It's asymptomatic in the initial stages, and it's reversible with reduced alcohol intake. So if you find out about it, or if for some other reason you quit or reduce your alcohol intake, it can reverse the alcoholic liver disease, which is great. The second stage is alcoholic hepatitis, where you get inflammation and cell necrosis, and you start that fibrous tissue formation, and the change becomes irreversible. Once you get that fibrosis, that's where you have the irreversible change. The liver is pretty resilient, but it's not that resilient. It can't recover from that fibrous tissue formation. End stage cirrhosis, the third stage, the fibrotic tissue replaces normal tissue, and you don't have any liver function anymore. And we know that the liver is essential to many of our functions, and you can't recover from that except with a liver transplant. So when you have cirrhosis and you have that fibrosis and cell damage, you get decreased removal and conjugation of bilirubin, decreased production of bile, so that affects your digestion, impaired digestion and absorption of nutrients, decreased production of blood clotting factors. You see how we're going downhill here? Impaired glucose and glycogen metabolism, that's that storage issue. Impaired conversion of ammonia to urea, that can build up and be toxic in your system. Decreased inactivation of hormones and drugs. So drug dosages, when someone's going into cirrhosis or liver failure, they have to be carefully monitored to avoid toxicity. And decreased removal of toxic substances, because that's what the liver does for us. So I have worked with people in the past who were going into liver failure, and they had to go off all of their medications. Even things like insulin and other things that were, treating other problems, their liver just could not handle the load on any kind of medications. So when we'll talk in the mental health chapter or the mental disorders chapter about different disorders. So you can imagine if somebody has a mental disorder that's well treated by medication and then they end up with liver disease, what's going to happen when they have to go off their medications? That's going to be a big problem. And I have worked with that patient more than once. So there's also a reduction of bile entering the intestine, so it impairs your digestion and absorption. There's the backup of bile in the liver, so that leads to obstructive jaundice. There's a blockage of blood through the liver, so that leads to portal hypertension. And there's congestion in the spleen, which leads to increased hemolysis and all of the associated effects of that. So inadequate storage of iron and B12, and that causes problems. Congestion in intestinal walls and stomach because of the impairments in digestion, and then that further impairs digestion and absorption. Development of esophageal varices and potential hemorrhage of those. Development of ascites, which is an accumulation of fluid in the peritoneal cavity. It causes abdominal distension and pressure. That ascites can also interfere with your breathing because the abdominal distension doesn't let your lungs fully inflate. So it's a cascade of problems. So this little slide talks about the development of ascites, and it largely has to do with fluid shift because of chemical changes. So a lot of times the initial manifestations are mild and vague. That leads to late diagnosis. With advanced cirrhosis, the ascites and peripheral edema and increased bruising and jaundice and encephalopathy, which can affect cognition, are changes. Once you get to advanced cirrhosis, it's a pretty bad place to be. So here's your guy. He's got all of the different things. He's got confusion and lethargy from the encephalopathy. He's jaundiced. He's got pulmonary edema and potentially infections. Gynecomastia, which is the development of breast tissue in males. Splenomegaly, that's the enlarged spleen. All the digestive issues. Increased bruising, edema, ascites, liver fibroses, all those. So there are lots of problems from advanced cirrhosis. Least of all, not to mention death can result in that. So the treatment is usually avoidance of alcohol or whatever's causing it. So if it's a toxic cause, avoidance of the toxic chemicals. Supportive or symptomatic treatment. Dietary restrictions, balancing the serum electrolytes, paracentesis, which is where they're aspirating fluid out of the peritoneum, antibiotics to reduce intestinal flora, emergency treatment if you get rupture of those esophageal varices, and liver transplantation is the final step. So there's a chart in the book that's the common manifestations of liver disease. When you look at these, a lot of them are also manifestations of other diseases. A lot of things can, besides jaundice, which is pretty specifically liver, a lot of the other things can be caused by other problems. So it often leads to late diagnosis of liver disease, which we know leads to a poor prognosis. Liver cancer is the hepatocellular carcinoma is the most common primary tumor of the liver, and it's more common in cirrhotic livers because we get that tissue damage, and tissue damage causes problems. Secondary or metastatic cancer is where the cancer arises from areas served by the hepatic vein, or it spreads along the peritoneal membranes. Again, with a lot of digestive system cancers, initial signs are mild in general, and diagnosis usually doesn't occur until the advanced stages. So it's treated with chemotherapy, possible lobectomy where they take out one of the lobes of the liver, the affected lobe, radiofrequency ablation, which is where they kind of burn it out with radiofrequency, and sometimes people recover from it, sometimes they don't, but because diagnosis usually occurs in the advanced stages, people don't usually recover, or it has a low recovery rate. Onto the pancreas. The pancreas is another one of those organs that we just can't live without. We can't live without a liver. We can't live without a pancreas. So acute pancreatitis, just like any other of the itises, pancreatitis can be acute or chronic. So inflammation in acute pancreatitis, the inflammation of the pancreas results in autodigestion of the pancreatic tissue. So the acute form of pancreatitis is considered a medical emergency. If your pancreas is digesting itself, that's a huge problem because you need your pancreas. The pancreas, unlike the liver and the stomach and the kidneys and some of the other organs, the pancreas doesn't have a fibrous capsule around it. So if it's auto-digesting itself, because that's where it's producing all the digestive enzymes, the destruction can progress into the tissue surrounding the pancreas. And once you get tissue death around there, the substances released by the necrotic tissue lead to widespread inflammation. And so it's a bad scene, right? Hypovolemia and circulatory collapse can result from acute pancreatitis. So this is something that needs to be treated pretty urgently. Chemical peritonitis results in bacterial peritonitis from acute pancreatitis, and it can result in septicemia or acute adult respiratory distress syndrome and acute renal failure. So acute pancreatitis is nothing to mess with because it can kill you. It can be caused by gallstones. Remember, the gallstones can block up the ducts and cause problems in the pancreas. It can be caused by alcohol abuse. Sudden onset of acute pancreatitis may follow Thanksgiving, a large meal, or a large amount of alcohol. I say Thanksgiving because people tend to overeat on holidays like Thanksgiving. And so you can have sudden onset of acute pancreatitis after a large meal or consuming a large amount of alcohol. So severe epigastric or abdominal pain radiating to the back, that's the primary symptoms. And people with pancreatitis, there's no question about the fact that they're in 10 out of 10 pain. When they say severe, they're screaming. They are in horrible pain. Signs of shock are caused by hypovolemia. A low-grade fever until infection develops, and then the body temperature can rise after the infection develops. Abdominal distension and decreased bowel sounds because we're not getting digestion. Decreased peristalsis and paralytic ileus, where the ileum's just not moving. They test serum amylase levels, which is one of the enzymes delivered by the pancreas. First, the serum levels rise, and then they fall after 48 hours. Serum lipid levels are elevated because they're not being broken down by the pancreatic enzymes. Hypocalcemia and leukocytosis. The treatment is you don't eat. They stop all eating because we don't want to be producing more pancreatic enzymes. Treatment of shock and electrolyte imbalances and analgesics for pain relief. It's usually, if you have acute pancreatitis, you're going to be admitted to the hospital. So when you have someone where their oral intake is stopped, they're going to have the sign on their door at the hospital that says NPO, right? Nothing by mouth. So they are not allowed to eat. So this is the pathophysiology of acute pancreatitis. I like these little flow charts. They kind of tell you what's going on. So when you have the building up of those pancreatic enzymes, when they're activated inside the pancreatic ducts, that is the problem, because then the pancreas starts digesting itself. Pancreatic cancer is a really terrible cancer because the mortality is super high, close to 95%. The risk factors for pancreatic cancer are smoking and pancreatitis and dietary factors. The most common form is adenocarcinoma arising from the epithelial cells in the pancreatic ducts. Weight loss and jaundice can be early manifestations. It's frequently asymptomatic until well advanced. That sounds familiar, doesn't it, for the digestive system? Metastases occur early because the pancreas is not encapsulated. So those metastases can occur earlier. Very high mortality rate. Unfortunately, I have known many a person who has died from pancreatic cancer. Former patients of mine that I worked very closely with, family members, lots of people I know with pancreatic cancer, and because it is asymptomatic until it's well advanced, the progression is fast, and people die quickly.